Welcome to This Explainer. Today, we're diving straight into the fascinating double life of an absolute powerhouse organ, the pancreas. It's often completely overshadowed by the heart or the brain, but this organ quietly orchestrates both how we digest our food and how we balance our body's energy. But as you'll see, the very tools it uses to sustain us can, under the wrong circumstances, literally become instruments of its own destruction. Let's get right into it. Here is our roadmap for today. First, the birth of the pancreas. Then we'll look at the digestive exocrine engine, followed by the endocrine balancer. After that, we'll explore what happens when it attacks itself, and finally, chronic failure and its complications. All right, part 1, the birth of the pancreas and its embryological roots. To build a healthy pancreas, two completely distinct endodermal buds have to pull off this perfect anatomical dance in the womb. Right around week 4 of gestation, you have these two separate buds, the dorsal and the ventral buds, emerging from the caudal foregut. Now, the dorsal bud is the main builder here. It forms the body, the tail, and the superior head of the organ. But then comes the really intricate part. As the developing duodenum rotates, that smaller ventral bud has to swing all the way around dorsally just to meet and fuse with the dorsal bud by the 7th week. It's basically a microscopic ballet. But what happens when that embryological dance fails? Well, we get a condition known as pancreas divisum. If those two ductal systems don't merge correctly during that 7th week rotation, the patient is left with a divided drainage system. It's actually the most common congenital pancreatic anomaly out there. And why does this matter to us? Because having two separate restricted drainage ducts creates a massive anatomical bottleneck. And that bottleneck is a major risk factor for patients developing recurrent idiopathic pancreatitis way later in life. Moving on to part 2, the digestive exocrine engine. Basically, the ultimate factory. As we jump into the gastroenterology chapter of our source material, we really get to see just how vital the pancreas is for breaking down the food we eat. The exocrine pancreas is an absolute workhorse, guys. It churns out a staggering 1.5 liters of fluid every single day just to make sure we can extract nutrients from our diet. That's enough to fill a large soda bottle every day just from this one organ. So the crucial thing to grasp here is this incredible division of labor between two specific cell types. On one side, we've got the acinar cells. Think of these as your heavy machinery operators. They secrete the super potent digestive enzymes. You've got amylase for carbs, lipase for fats, and proteases for proteins. And your cue to get to work? A hormone called CCK, which drops in when fat and protein enter the gut. On the flip side, we have the ductal cells. These guys act as the environmental control. They secrete a massive amount of alkaline, bicarbonate-rich fluid stimulated by the hormone secretin. This fluid completely neutralizes that harsh stomach acid, creating the absolute perfect pH environment so those acinar enzymes can do their job safely. And this division of labor creates a highly controlled domino effect of protein digestion. But crucially, it happens safely out in the gut lumen, not inside the pancreas itself. See, the pancreas secretes its proteases in a deactivated, safe mode. We call these zymogens. If they were active inside the pancreas, oh man, they would literally digest the organ itself. The master key to this whole system is an enzyme called enterokinase, which only hangs out on the brush border of the duodenum. When the inactive trypsinogen reaches the gut, enterokinase clips it, flipping it into active trypsin. Trypsin then rapidly activates even more trypsinogen, plus the other zymogens. It's this beautifully contained biological explosion that only goes off exactly where it's supposed to.
That brings us to part 3, the endocrine balancer, our center for metabolic control. Because beyond digestion, the pancreas moonlights as a master metabolic controller. It manages this delicate seesaw between insulin and glucagon to ensure our blood glucose stays perfectly balanced. Deep within the islets of the pancreas, the beta cells act as our body's rapid response storage managers. When you eat, they quickly secrete insulin, which is an anabolic hormone that drives glucose straight into your cells and promotes storage. But when you're fasting, the alpha cells take over. They release glucagon, a catabolic hormone that steadily tells your liver to break down stored glycogen and slowly pump that glucose right back into the blood. It's a minute-by-minute balancing act that is absolutely essential for our survival, especially for our brain, which literally demands a constant supply of glucose. But considering all those incredibly powerful digestive enzymes we just talked about, we really have to ask a dangerous question. What exactly happens if this highly controlled factory turns on itself? Well, that takes us to part 4, when it attacks itself, also known as acute pancreatitis.
When those biological safety locks we mentioned earlier fail, the consequences are incredibly violent. We're talking about a devastating cascade where the pancreas quite literally digests itself. Remember that domino effect with trypsin? Well, in acute pancreatitis, the master enzyme trypsinogen is prematurely activated into trypsin right inside the acinar cells of the pancreas, instead of safely out in the gut. Now, the pancreas does secrete a safety molecule called SPINK1 to stop rogue trypsin, but if the activation is too massive, SPINK1 just gets completely overwhelmed. The organ begins to autodigest. This triggers a massive local release of inflammatory cytokines like TNF-alpha and interleukin-6, and the scary part? This doesn't stay local. It spills right into the bloodstream, causing systemic inflammatory response syndrome, or SIRS. It's essentially a massive whole-body alarm system going off, and it can rapidly lead to multi-organ failure.
So what actually triggers this? To remember the causes, medical professionals use this fantastic mnemonic: get smashed. The most common triggers by far are gallstones, which block the drainage duct, and ethanol, meaning heavy alcohol use, which directly damages the acinar cells. But honestly, the sheer variety of things that can trip this premature enzyme activation is staggering. We're looking at everything from severe hypertriglyceridemia to certain medications to, believe it or not, scorpion stings. Seriously, who knew scorpions hated the pancreas? When it comes to diagnosing this, testing the blood for lipase is your superior detective tool. While both amylase and lipase enzymes will spill into the blood during a pancreatic attack, amylase can actually also come from the salivary glands, which makes it a bit less specific. Lipase, however, is not only way more specific to the pancreas, but it also remains elevated in the bloodstream for a much longer period after the initial attack. That makes it the absolute gold standard biomarker for catching acute pancreatitis. And finally, part 5, chronic failure and complications, the aftermath.
Following repeated attacks or chronic damage, the organ begins to permanently break down. We transition from an acute emergency to a long-term systemic failure. Chronic pancreatitis isn't just about chronic pain, it's a devastating breakdown causing everything from fat-soluble vitamin deficiency to type 3C diabetes. This constant cycle of inflammation and healing replaces healthy, functional tissue with hard, fibrous scar tissue. As the acinar cells die off, patients lose their digestive enzymes, leading to malabsorption and fatty, foul-smelling stools known as diarrhea. As the islet cells get caught in the crossfire, your endocrine balancer fails, resulting in type 3C diabetes. The scarring can even compress the splenic vein, causing left-sided portal hypertension. And perhaps most terrifyingly of all, this chronic inflammatory state significantly increases the risk of pancreatic ductal adenocarcinoma, which is one of the most aggressive cancers we know of. But here is an absolutely astonishing fact. The pancreas is so incredibly resilient that exocrine insufficiency only develops when over 90% of its functional parenchyma, its working tissue, is completely lost. 90%. This is a massive testament to the organ's initial reserve capacity. A patient could be quietly losing pancreatic tissue to chronic alcohol use or a genetic mutation for years, completely without symptoms, all because that remaining 10% is working overtime to compensate. By the time malabsorption and weight loss become visible to us, the destruction is already vast and, sadly, irreversible. To diagnose this failure, we look for fecal elastase 1. When evaluating a patient for chronic exocrine insufficiency, we really need to know what their pancreas is actually producing. Fecal elastase 1 is an enzyme made by the pancreas that passes completely unchanged through the gut into the stool. It's incredibly specific, and its absolute superpower as a diagnostic test is that if we're trying to treat the patient by giving them oral pancreatic enzyme supplements, those pills won't artificially inflate the fecal elastase test results. It's a wonderfully reliable marker. We've seen how the pancreas is a miraculous builder, beautifully digesting our food and balancing our energy. But we've also seen how a single misstep in its complex internal chemistry turns it into a breaker, literally destroying itself from the inside out. So with an organ that successfully hides its damage until 90% of it is gone, I'll leave you with this question. How can medical science better intervene before that very first domino falls? Thanks for joining me on this explainer, and we'll see you next time.